Okay, good evening again. It's Dr. Lesoho Mawela from the Aqua Training School, and this is part of our weekly virtual lectures on NIMART, specifically focusing on HIV management. Today's topic is going to be about some of the principles that we have to know and adhere to as we manage people living with HIV and AIDS. It is actually a subtopic from our basic HIV, AIDS, STI, TB, and management program as part of the NES initiation and management of ARVs, which is NIMART. Just to give you a quick overview of our school, just to say that it is our vision to see a better society where everyone achieves their full potential. So we provide a number of training programs which help people to achieve their full potential. We provide both accredited and non-accredited professional development programs. Specifically in terms of nursing, these are some of the key programs from NIMART, adult primary care, IMCI, dispensing, and some of the soft skills around quality improvement, leadership management, and also soft skills. Right. So I just want you to, as we start, to get used to one of the engagement approaches we would be using today. So I have a first question for you. Let me see if I'll be able to engage with this. Yes. So I have a question. All you need to do is to choose the one that suits you best. So the first poll or engagement question for today is, I want to know, how is your mood? Are you happy? Is it neutral? Is it sad? Maybe you are not sure. So let's select the one that best suits you, and then I will then share the results with you. So I see 60% of you have voted. I'm hoping that all of us, we will make the vote. Yep. All right. So we just gave it just a minute. You can only select one answer, so don't try to have more than one mood for today. Yes. So I'm gonna end the polling. That means you won't be able to, but I want to show you the results. So if you look at the results for today, is that about 48% of us are happy. Another 44%, which is 11 of us, are neutral. 1% is not sure how they feel. So I'm hoping that, through this program, will help you to at least get your mood to be happy. And I see that we have one set member of our family here. So whatever is going on, we wish you well, and we want to say, be comforted. And I'm hoping that through this training program, I'll be able to also, inspire you so that you are at least neutral, if not happy, which is the ultimate goal. So thank you very much for sharing with me your mood and how you feel. So we will then continue with the workshop. So today's topic is the do's and don'ts of ART therapy. I also call this topic the principles of managing ARVs. So I'll take you through the goals and rules of ART therapy, safe ART initiation process. So how do you safely initiate patients on ARVs? Then we will close this topic by looking at the precautions for ART therapy. We don't have a clinical case, but hopefully, towards the end of this session, we will have enough time for you to ask specific questions, and from the case studies, either through your studies or in practice from your clinic, I'll be very happy and excited to engage you further. So remember, as you treat patients living with HIV and AIDS, right, you have to have a bigger view, especially about the future options for the patient who will be in front of you at that point in time. One of the goals of the HIV/AIDS program is to improve the quality of life for people living with HIV and AIDS. And they will achieve this by reducing morbidity, and mortality, which is deaths. So we want to increase access to ARVs to as many people as possible, so that people do not necessarily need to be admitted regularly, but they can also go back, to their jobs and live with their families. We also want to restore and preserve the immune function. And what we know today is that it's very important to start people who are living with HIV and AIDS on ARVs as soon as they test positive. Historically, we would wait until someone has a very low CD4 count. And what that did was to lead to a situation where most patients would start with low CD4 counts. It will take them years before they recover. Even when they have fully recovered, you'll find that they still get quite a number of opportunistic infections and so on. So we know that to preserve the immune function is strongly linked to early initiation of ARVs. We also want to give a combination of drugs that are able to suppress the virus in the blood to undetectable levels. But this suppression should not be just for 2 weeks or 3 months or even 2 years, but it should be durable. So you want to give a combination of drugs that would suppress the virus, but give you a suppression for as long, as possible. We do know that we have people who had been on ARVs for over 30 years now, right? So that means we want regimens where people can start them and still prolong their lives, as long as possible. Now, as you play around with drugs, switching drugs and saying this one has a side effect, we need to stop this drug and switch it with this other drug. Remember, every single switch you do limits future options for your patients. So it's very important that we do not have a culture of stopping and switching drugs, when it's unnecessary. Whenever you stop a regimen and you give the next regimen, it means now your patient does not have as many options in the future should they need more drugs or even drug regimens. Rational sequencing of therapy is very key and important. That means there are certain drugs that are preferred as a first-line regimen, so that when patients fail that first regimen, we still have drugs that we can use as second line or even third line. So we do not want a situation where a newly diagnosed patient is automatically started on third line regimens, as an example, where if patients fail, some of the drugs will confer resistance to even other drugs that the patient had not taken before. So there is a sequencing, where we start with tenofovir, and if patients fail, we want to give them zidovudine. We want to avoid a situation where we encourage most of our patients to be started on zidovudine as part of their first line. We also want to maximize adherence by the way we select the drugs. So we select drugs that have minimal side effects, drugs that are very easy to take, drugs that can be taken once a day, and preferably in a combination tablet where it's one tablet once a day, and I mean, that is the ideal situation that we are looking for. So remember, as you treat your patients, it's not just about the disease, but it is also about the future options and preserving the drugs they might need in the future should things go wrong. ARVs work. So monotherapy in the early days in the 80s, when there was only one drug like zidovudine, which is called AZT, we used to rely on monotherapy. We know that it does suppress the virus, but it is not durable, right? So it might suppress the virus for like 1 or 2 days. By next week, the viral load is very high and patients are failing. Dual therapy, if you use 2 drugs, can also suppress the virus, but it does not give you a sustainable, durable viral load suppression. So we do not recommend that we should be giving patients, 2 drugs. However, it is a combination of 3 drugs. Always we use 3 drugs. We never treat HIV with 1 or 2 drugs. And I will show you shortly the principles around how then do you formulate an effective combination of drugs for your patient. But before I go there, I want you to test your knowledge. Don't feel very under pressured, and say, ooh, why is Dr. Mawela now testing? We won't even know who answered which question. But I want to share the first question with you, and then just select, based on your knowledge. It's not about getting it wrong or getting it right. So the question is, which of the following drug classes, so it's possible that you don't know much about the drug classes, don't worry. So which of the following drug classes is the recommended combination for the first line regimen in South Africa? So if you look at, if you have a newly diagnosed HIV positive patient today, are you going to give them a combination of an NRTI plus an NRTI plus an NNRTI? I'm sure some of you are saying, yes, I know that. Some of you are saying, oh, what is this, doctor? Or it will be two NRTIs plus an integrase inhibitor, or with a protease inhibitor. It's possible that you are not sure. There's two questions. So once you are done with the first one, click next and move on. I'm going to give you just another 30 seconds. Try to participate. It should be fun. We will never know which one you selected. And I think it will help you when I take you through, the theory around that. I'm giving you a bit of time. Come, guys, come on. Yes, make it fun. If you are not sure and you are like me, it's still okay. Yes. Only 40% of you have answered. Choose something. Yes, that's good. And then you'll see, we'll go through the theory and it will help you to reflect on your selection. And then at the end, you'll get another chance to take the same question. And let's see if the statistics would change. Okay, I'm going to stop in the next 2 seconds, the voting. I see 73%, 76% of us, 29 over 38 have actually voted. So I'm going to stop it there. And then we will then discuss the answers. Just a few seconds. Right. Let me show you the results in terms of how everyone has voted. Yes, so there are your results. So you can see that in terms of the first question, which of the following drug combinations is the first combination? Okay, first line combination in South Africa. I think there's a typo there. 34% said two NRTIs with an NNRTI, and then about 41% said two NRTIs with an integrase inhibitor. 7% said with a protease inhibitor, and at about 17% of us are not sure. So we will look at that. And then in terms of the second question, which of the following drug combinations is the preferred first-line ART regimen? We've got about 30% who say tenofovir, emtricitabine, and efavirenz. 0% have chosen abacavir. No one is not sure this time around, so it's quite interesting. And then about 72% chose tenofovir, lamivudine, and dolutegravir. All right. So let's then continue with the teaching. A few seconds. Good. So let's continue with the teaching and see. So if you look at the HIV life cycle, which is not today's topic, but it gives you, the background around that first question about which drug classes. So if you are lost, you need to pay attention to this, right? So if in green there, you have the HIV virus with its nucleus, and then also 2 strands of RNA. And maybe in this color, this light pink color, you've got a white cell count, which expresses a CD4 receptor on it. HIV would naturally infect cells that are called CD4 cells. So this cell here, right? The way HIV infects the cells, it's like a 4 to 5 step process. The first part, it is the attachment. So where HIV attaches to the CD4 cell membrane. Immediately after that, the two membranes, the green membrane there and this light pink membrane will then join or fuse, right? As soon as attachment and fusion has happened, you can see now that that genetic material, the two RNA strands, these ones, are therefore released into the cytoplasm, right? The first enzyme, which is very important at this level, I know there are drugs that act at that stage. I don't want to talk about them for tonight. There's an enzyme called reverse transcriptase. So it's an enzyme, right? It converts this RNA into DNA, right? The HIV virus is an RNA virus. We are DNA species. So there's an enzyme that facilitates that conversion there from RNA to DNA, and it's called reverse transcriptase. That's the enzyme. Now we've got drugs that inhibit that enzyme. They are called reverse transcriptase inhibitors, right? These reverse transcriptase inhibitors, we have two kinds. We've got what we call the NRTIs and the NNRTIs. So you've got your nucleoside reverse transcriptase inhibitors and your non-nucleoside reverse transcriptase inhibitors, right? So these are drug classes. So when you say what are the classes of the drugs, you say, well, firstly, I know that there are drugs that inhibit this enzyme. They are called reverse transcriptase inhibitors. There's two kinds, nucleoside and non-nucleoside, right? Now, if RNA is converted to DNA, it is then transported into the nucleus of this CD4 molecule of ours. And in the nucleus, the blue, you can see there's a blue strand there, right? Which is then integrated with our DNA. So now you've got this DNA from the virus being integrated with the human DNA, which comes as part of the white cell there, or a CD4 cell as we see it. Now, there is an enzyme that facilitates the integration of this DNA, the viral DNA, into our own human DNA. And it's called integrase. Integration, integrase. So we've got drugs that are called integrase inhibitors. So these drugs, how do they work? They stop this enzyme so that the viral DNA is not combined or integrated with our DNA, right? And then should this DNA be successful and it's integrated with our DNA, new baby viruses would be formed through long strands of proteins, right? These proteins, they need to be cleaved or cut into small proteins. And the enzyme that facilitates the formation of new viruses is called protease. Now we've got drugs called protease inhibitors. So if you look at all the ARV drugs, you can classify them as either reverse transcriptase inhibitors. They are either nucleoside or non-nucleoside reverse transcriptase inhibitors. And if you look at your nucleoside reverse transcriptase inhibitors, we're talking about drugs like tenofovir, lamivudine, abacavir, zidovudine, and emtricitabine. So those are your nucleoside reverse transcriptase inhibitors. Then you've got your non-nucleoside reverse transcriptase inhibitors. These would include efavirenz and nevirapine. There's newer ones. They are beyond the scope of this workshop, but you need to know at least something about efavirenz and nevirapine. Now, these are your reverse transcriptase inhibitors. Then I said there's an enzyme which is blocked by integrase inhibitors. That enzyme is called integrase, right? So a new drug called dolutegravir, that is the main drug you need to know at the NIMAT HIV management level, is what we call dolutegravir, right? This is not English. You have to pronounce these names to know them. And then a protease, which is inhibited by protease inhibitors. A key drug is what we call lopinavir in combination with ritonavir. So you know, so when you go back to those classes, that is what we are talking about. So if you look at ARV drugs, we always use 3 drugs, but it's not just, you cannot just take any 3 drugs, put them together, say, but doctor, you said I must use 3 drugs. Yes, I said 3 drugs, but there are rules. There's a structure that you must follow, right? So it should always be 2 nucleoside nucleoside reverse transcriptase inhibitors plus an integrase inhibitor. If you remember, I said here on the integrase inhibitor, we talk about dolutegravir. On the nucleoside reverse transcriptase inhibitors, the nucleoside ones, I said you're talking about a drug like tenofovir, abacavir, lamivudine, emtricitabine, zidovudine. So you combine those 2, and I'll show you now how you do that, right? Or it's 2 nucleoside plus an NNRTI, so non-nucleoside reverse transcriptase inhibitor. Like which one? These 2 drugs, nevirapine or efavirenz, right? Or 2 nucleosides plus a protease inhibitor with ritonavir. So this is where I said lopinavir with ritonavir. These are principles, never break them. If you give a different regimen compared to what I'm showing you now, you are going to cause more harm to your patients and rather than to do good. So we don't give 3 nucleosides together, for example, right? Or 2 NNRTIs together, or 2 integrase inhibitors together. It's always 2 nucleosides. Then you choose, am I giving it with an integrase inhibitor or a non-nucleoside reverse transcriptase inhibitor or a protease inhibitor? So we'll come back to this. So if you look at some of the drugs that we use, you've got tenofovir. It's a nucleoside reverse transcriptase inhibitor. You've got your abacavir. Again, it's an NRTI. Even here, we've got an NRTI, right? 3TC, it's lamivudine, emtricitabine, right? Together with zidovudine. So if you ask you what are the NRTIs, nucleoside reverse transcriptase inhibitors, you say, well, doc, it's tenofovir, abacavir, lamivudine, emtricitabine, and zidovudine. Then you've got your 2 non-nucleoside reverse transcriptase inhibitors, the common ones, it's nevirapine and efavirenz. Then I said we've got your integrase inhibitors. I said it's dolutegravir, right? And you can see there's some notes around avoiding the first trimester. If you're giving tenofovir, check the kidneys, and so on. Nevirapine should not be used with TB treatment. So there's quite a number of precautions about each drug. And you've got your lopinavir and ritonavir, which is a protease inhibitors. In other words, when you prescribe a regimen, you always use 2 nucleoside reverse transcriptase inhibitors. For example, tenofovir, lamivudine. Those are your 2 nucleoside reverse transcriptase inhibitors. Then you have to choose, are you going to use an integrase inhibitor as a 3rd drug or a non-nucleoside reverse transcriptase inhibitor, efavirenz, or even a protease inhibitor like lopinavir in combination with ritonavir. So that is how these drugs work. So if you look at now the standard first-line regimen in South Africa, what is our standard first-line regimen? So if you have a patient that you have to start on ARVs, how do you combine the drugs? So you can see it's 1 NRTI plus 1 NRTI plus an integrase inhibitor or a non-nucleoside reverse transcriptase inhibitor. So our standard first-line regimen in South Africa, right? It's a combination of tenofovir, lamivudine with dolutegravir. So you want to give 99.9% of patients this regimen. Where you cannot give dolutegravir, then you can use efavirenz, right? Where you cannot give tenofovir, you can then opt for abacavir. Where both tenofovir and abacavir cannot be used, therefore you are left with zidovudine, right, which is AZT as you see it. And there's something which is common here is that the middle NRTI. So you choose the first drug and the third drug, but the middle NRTI is always lamivudine or emtricitabine, and they can be used interchangeably because it's the same drug, right? So already when you have to decide on a regimen, the middle drug is already given. It's always lamivudine or emtricitabine. So here you don't choose. It's already given. Then you have to give TDF. If you cannot give it, then abacavir. If both of them cannot be given, then zidovudine. So you change in that direction, right? Even here, you always want to give dolutegravir to all your patients where maybe you have concerns about dolutegravir. She's 1 week pregnant and you think there might be problems with the baby. Then you give efavirenz. In a situation where both dolutegravir and efavirenz cannot be given, then your option is lopinavir and ritonavir combination, right? So in terms of that second question on the poll there, this would be the preferred standard regimen in South Africa. It will be tenofovir, lamivudine, and dolutegravir. In terms of classes, drug classes, you will say NRTI plus NRTI plus integrase inhibitor. That becomes, your choice in terms of how you approach your patient. And we always want to use fixed dose combinations. Try to avoid giving patients too many tablets to take. We want to enhance adherence. So if you look at this regimen here, tenofovir, lamivudine, and dolutegravir, it's available as a 1 tablet once a day, anytime, because you don't have to take it at night. Even in the morning you can take. So it will be tenofovir, 300 milligrams plus lamivudine, 300 milligrams, and dolutegravir, 50 milligrams. You see, now you have formulated a regimen and you didn't cram it. You know the science behind why you have opted to give this particular regimen. Where you cannot give dolutegravir, you would then give efavirenz as a 600 milligrams. And again, tenofovir, emtricitabine, and efavirenz, it's a 1 tablet once a day. And like I said, lamivudine and emtricitabine is the same drug. We use them interchangeably as needed. Where there is a problem with tenofovir, maybe the patient has kidney problems, you would then go and use what? Abacavir. You don't go to zidovudine first. You move from tenofovir to abacavir, which is also available as a combination with lamivudine, and then you add either dolutegravir or efavirenz based on the history of your patient. So this is how these drugs, we have moved from classes NRTI plus NRTI to integrase inhibitor to specific drug names following those rules. And now they are even available as 1 tablet containing all the 3 drugs that you might need to prescribe for your patient, right? So remember, we don't just give drugs. We have to prepare patients for ARVs. In preparing patients for ARVs, you have to consider whether they are eligible for some of the prophylaxis therapies. We need to collect the baseline CD4 count and stage our patients. We need to do a TB screening. If your patient has STIs, oral candida, any opportunistic infection, it's always best to treat it before you start ARVs. Let's not forget that we are dealing with human beings, so the psychosocial aspects are very critical and important. Once your patient is ready, you assess, are you ready? Says, yes, I'm willing. Then you prepare them for ART, you choose the regimen, and you initiate them on an appropriate regimen. Now, when it comes to then, how do you go about initiating someone on ARVs? We don't start by prescribing the drugs, right? You have to take proper history from your patient. Are they having any other complaints? What concerns are they having? You have to examine them. You have to do tests like your urine dipsticks, pregnancy test, because if you don't know answers to those tests, you can't give any ARVs. How would you know which ARV to give? For example, if she's pregnant, some drugs you must avoid. If she's not pregnant, some drugs are safe, right? So we have to follow, the history taking examination, basic tests that you can do in your clinic. Then you give the medication. But how do you give this medication? You follow these 4 steps. The first step says you have to determine the time frame. Is this a patient that you can initiate today? So if the patient has TB, which they started treatment last week, it's best to treat TB for 2 weeks first before you start them on ARVs. Is this a patient who has been exposed to ARVs before? Most patients are new patients, so you start them on the standard first-line regimen, which is tenofovir, lamivudine, and dolutegravir. However, if it's someone who was on ARVs, they defaulted, they stopped, you might need to consider giving them second line, especially if they had failed first line at that point in time or they were already on second line regimen. So it's important that you determine if this is a person I can start today. Is this a person who has taken ARVs before? And then which are the 3 drugs that are suitable for this patient based on your history, examination, and test, point of care test outcomes. Then step 4, based on the drugs that you have chosen, you then say, I will do a creatinine, for example, if my patient is going to be given tenofovir. So I'll show you now. So if you look at step 1, all pregnant women must be started on ARVs same day. And then even adults and children who are HIV positive and stable, no complaints, no opportunistic infections, they test positive today, there's good social support, the patient is willing to be on ARVs, you initiate them on ARVs. If you've got a severely, significantly immune compromised patient, you might have to wait for about 7 days because you'll be doing some tests and waiting for blood results. Some patients might be started even on your fluconazole prophylaxis therapy. So you want to assess them properly and see, how quickly can you assess them. If a patient is taking TB treatment, you want to make sure that the TB has been treated for at least 2 weeks before you start ARVs. If you look at patients who've got very bad conditions like cryptococcal meningitis and TB meningitis, you're not going to start ARVs before you treat these conditions. So generally, we would treat these conditions for 6 weeks first, and then we take things from there, right? So if, let's say, it's a stable Dr. Mawela who's willing to start, their wife and kids are there, they are supportive, and is this person you can start on the same day, you would then say, Dr. Mawela, have you ever taken ARVs before? Then I say yes, then you need to assess why did I stop. If I say no, then it means I must start on the standard first-line regimen, which would be tenofovir, lamivudine, and dolutegravir. Then which drugs are suitable for your patient? If she's pregnant, she's in the first trimester, you don't want to give dolutegravir. If Dr. Mawela has proteins in urine and he's a known renal patient, you want to avoid the use of tenofovir. But where does it start? All your patients, you want to give them this regimen. This is our priority regimen. This is the best safe and effective regimen we have: tenofovir, lamivudine, and dolutegravir. Most patients should receive this regimen. It is available as a once daily. However, we need to assess if there are problems with tenofovir or dolutegravir, right? Where you cannot give tenofovir, you then use abacavir. You see, as simple as that. He's got kidney problems or other issues, you say, fine, I'll use abacavir. And then where you cannot use dolutegravir, especially most of the time it will be women in their first few weeks of pregnancy, you then have an option to stop your dolutegravir and give them efavirenz. So they'll take tenofovir, lamivudine with efavirenz. Where both dolutegravir and efavirenz are contraindicated, therefore lopinavir, ritonavir becomes an option. These are rules, right? And processes that you need to follow all the time. So again, where you cannot use dolutegravir, tenofovir, lamivudine, and you have to decide whether you'll use efavirenz or lopinavir together with ritonavir. So quite an interesting. So remember, once you have chosen your drug, so for Dr. Mawela, we chose tenofovir, lamivudine, with dolutegravir. So we chose the standard first-line regimen for Dr. Mawela. If you look at it, dolutegravir, you don't need to do any blood test to monitor this drug. Lamivudine, you don't need to do any blood test to monitor this drug. Tenofovir, yes, you need to monitor tenofovir by you doing a creatinine and creatinine clearance. And remember, any patient who's got a creatinine clearance less than 50, from a NEMAT perspective, nursing perspective, you need to refer them. You might stop tenofovir, give them abacavir, but you need to refer them for further assessment by a doctor, even if it's a visiting doctor at your clinic. Zidovudine, if a patient is taking zidovudine, you then do an HB. If they're taking nevirapine and ALT, if you're going to give lopinavir, you need to do your lipid profile because they tend to have high cholesterol levels in the blood. So the message about this slide is that you don't just do all the tests, right? There's standard tests that you do, something like TB screening, urine dipstick, pregnancy test, pap smear. You do it across, but these specific tests are only done based on the drugs that you would have chosen for your patient. So in other words, if you're not prescribing zidovudine, you are not going to do an HB. If you're not prescribing nevirapine, you're not going to do an ALT, right? So that is very important. So that is the 4-step initiation process, determining whether you can initiate today or you need to delay for a week or two. Has the patient been exposed to ARVs? If no, then you can give them the standard first-line regimen, tenofovir, lamivudine, and dolutegravir. Once you have chosen your drugs, you then develop, you then assess the additional tests that you need to do to monitor these specific drugs. Always explain, remember, patient education is key. Explain the medications, how to take it, how not to take it, when to take it, and what kind of side effects will our patients experience, and then how then do they manage it as such, right? So just to make sure that you don't leave me alone here teaching, I have another question for you. So let's see if I'll be able to navigate here. Yes. So I hope it's just one question this time around. I'm hoping it will engage you. Then we will look at these questions again. So I've shared a question. Please get engaged, come back and get engaged. It says, which of the following drugs should never, so never be given in a TB, HIV co-infected patient taking rifampicin as part of TB treatment? Which of these ARV drugs should never be given? Should never be given. I'm not sure, so I'll also select not sure, but what is your choice? Come guys, come guys. I see only 20% of you have selected. Come on. Yes, that's better. Come guys. Yes, we are now at 50%. Let's go for it. All right. All right. 5 more seconds before we stop. We are at 85% of votes. Unfortunately, I have to cut. I hope all of you got a chance to vote. So let me show you the results so that you can then think through your selection. So about 3% said tenofovir, another 3% said efavirenz, 6% said dolutegravir, 64% said nevirapine, 8% said lopinavir, ritonavir, and 17% are like me. They're saying, oh, doctor, please, you are stressing me. I'm really not sure. So that's fair enough. So let's then take it from there, and then I think we will get somewhere together, right? So interesting answers. So here's the discussion. So when a patient is TB HIV co-infected, And they are taking both TB treatment that has rifampicin and ARVs. Just remember this sentence. Rifampicin is a liver enzyme inducer. That means this drug activates the liver enzymes, and when these enzymes are activated and hyperactive, they then consume any other drug that goes through the liver very quickly. So if you give the normal doses of these drugs, you tend to have very low drug levels in the blood, right? So let's look. The first group is your NRTIs. So tenofovir, lamivudine, zidovudine, lamivudine, which is the abacavir. All those drugs, because they are metabolized through the kidneys, they are not affected by rifampicin or anything that affects the liver. So if you had selected tenofovir, it means your answer was incorrect. Abacavir, incorrect. Zidovudine, incorrect, right? Now, dolutegravir, the drug levels of this drug are reduced by rifampicin. Therefore, under normal circumstances, we prescribe it as 50 milligrams per hour daily. When a patient is also taking TB treatment, we increase the dose to 50 milligrams BD. Now, that question was saying we are looking for a drug where you should never give it. So with dolutegravir, it's not that you should never give it, but you need to increase the dose, right? Efavirenz, yes, is metabolized in the liver, but the interaction with rifampicin is of no clinical significance. Therefore, it is a drug that you can give with rifampicin. There are no problems, right? Nevirapine should never, in red there, should never be given with rifampicin because of two reasons. They share the same side effect. That is the first issue. That is the first issue. They share the first side effect. And number two is that the drug levels of nevirapine are reduced significantly. So you should never give these drugs together. In terms of lopinavir, is the same as dolutegravir. It's not that you should never give it. However, when you give it, you need to increase the dose, right? If the patient is taking tablets, you can double the dose, because if there's no TB, like the patient is not taking rifampicin, the standard dose is to prescribe 400 milligrams over 100 milligrams per os BD. This is where there is no use of TB drugs, right? As soon as a patient takes rifampicin and it's tablets, they're taking lopinavir, ritonavir tablets, you are allowed to just double the dose. So if they were taking 400, you give 800. The 100 becomes 200, right? If it's a syrup, like a child who gets TB and they were taking 2 mils of lopinavir, ritonavir, you cannot double the dose of syrups. For syrups, you need to prescribe additional ritonavir. So that is a very key. So just remember that part. So in terms of that question, if the question was to say which drug should never be given with TB treatment, it's nevirapine. Efavirenz is not affected. Your tenofovir, lamivudine, abacavir, zidovudine, not affected. Dolutegravir, you increase the dose from 50 milligrams daily to twice a day. Lopinavir, you either double the dose or you add additional ritonavir. Are we together? I hope you are able to reflect on that question, right? We will look at all those pollings again at the end. So one other thing which is very crucial, which is a very important principle. Remember, when you start patients on ARVs, you have to do a hepatitis B test. Hepatitis B is a virus also. And this is because at a later stage, should you want to stop some of the drugs, you need to check what is the hepatitis B status of your patient. So like I said to you, the standard first-line regimen in South Africa is tenofovir with lamivudine and dolutegravir, right? Just remember that we start almost all patients on this drug. So the three drugs are able to treat HIV. It's very important to note that these two drugs, which are part of the standard drug, tenofovir and the lamivudine, also are active against hepatitis B. That means if you do a baseline test and the patient has HIV and hepatitis B, by prescribing this regimen, you are treating two conditions at the same time. You are treating HIV and you are also treating hepatitis B, right? Whenever you need to stop any of these two drugs, you need to check the hepatitis B status of that patient, because if it was positive, you should never stop these two drugs, right? And a typical example is that if you look at someone who started on treatment, we'll give them tenofovir, lamivudine, and dolutegravir. They will take the drugs maybe for 2 years, 5 years. Later on, they start to have high viral loads of HIV. They are failing treatment, and we need to switch them to second line. If you look at our second line for patients who fail this regimen and they need a new regimen, we would then give them zidovudine, lamivudine, together with lopinavir, ritonavir, if they have failed dolutegravir. Now, what is the problem with switching from this regimen to this regimen? Is that if there's no hepatitis B, this is not a problem. It's actually a perfect regimen because we have stopped tenofovir and we have given zidovudine. However, if the patient had hepatitis B, that's why before you switch, you must check hepatitis B status for those patients. If the hepatitis B status is positive, you should never stop these two drugs, right? Therefore, a patient who needs a second line regimen, so they were taking this regimen, they had two viral loads that are high, and we think they have failed this regimen. Now we want to give them second line. Yes, you give them second line, zidovudine, lamivudine with lopinavir, ritonavir, but we note that the patient also has hepatitis B. If they have hepatitis B, we should never stop TDF, right? So the patient will take 4 drugs, zidovudine, tenofovir, lamivudine with lopinavir, ritonavir. The 3 drugs, zidovudine, lamivudine, and lopinavir for HIV, and then we keep these 2 drugs to ensure that the hepatitis B is also properly managed. So it's a clinical issue where if you stop tenofovir in a patient who's got hepatitis B, they would get a very high viral load of hepatitis B and come back with signs and symptoms of liver failure. So we don't want that to happen. These are the principles, and as I summarize this presentation, remember the critical issues I have raised. So in terms of summarizing the do's and the don'ts or the principles, just remember the first bullet there. Don't initiate ARVs with an assumption that patients are going to be good people and adhere. Make sure that you take an approach that poor adherence is likely. Therefore, you must take precautions. Educate your patient, ensure that there is support, help them with reminders, bring additional treatment buddies, simplify your regimen by reducing the number of tablets and probably, giving them that one tablet, 3 drugs in one tablet combination. There are drugs that don't do well with high viral loads. A drug like abacavir does not like high viral loads, so pay attention to that. I've just showed you hepatitis B co-infection. Remember, if there's HIV and hepatitis B, you must always keep tenofovir and lamivudine in that regimen. Don't ever forget that, right? You need to check women of childbearing potential, because we know there are drugs, if they take and fall pregnant, these drugs, there's some level of anxiety and risk, especially dolutegravir, that, in the first trimester, especially the first 6 to 8 weeks, we want to avoid its use. So we prefer women to be on reliable contraception before we give them certain drugs. If they are already pregnant in the first trimester, again, we want to avoid the use of dolutegravir. If it's a patient who's got pre-existing kidney disease, which drug? I told you, tenofovir. So pay attention, if they've got the protein in urine, it's a patient on dialysis, you don't want to give them tenofovir, right? Always assess, your cardiac risk. Patients who are having diabetes, they're hypertensive, the cholesterol is high. There are drugs that are known to increase cholesterol in the blood, like lopinavir, ritonavir. Abacavir is known to be linked with myocardial infarctions. So that's why you must always, you see, all these things I'm raising here, they've got something to do with proper history taking and physical exam, which then determines the drugs that you choose for your patient. We have a psychiatric disease. So, active psychosis, for example, is an absolute contraindication to the use of efavirenz. So we don't want to give efavirenz in patients who have psychosis. TB treatment, I've already discussed with you to say avoid the use of nevirapine. If they are on dolutegravir, increase the dose to BD. If they are on lopinavir and ritonavir, you either double the dose if it's tablets, or you then add additional ritonavir if it's a syrup. So those are the key things. Remember your NRTIs: tenofovir, lamivudine, abacavir, zidovudine, not affected by TB treatment. And then tenofovir can also cause thinning of the bones. Tenofovir, that's why we don't give it to children or anyone who's less than 10 years, right? We don't give tenofovir to patients less than 10 years or those with weight below 35 kgs because it can cause thinning of the bones. We don't want to affect the growth of our kiddos. This is the last slide. And it talks to additional things to say, remember, you can play around with drugs, stop this one, give that one, but the viral load must be suppressed. We never change tenofovir and give abacavir in patients who have high viral loads. So that's not how we manage it, right? Where the viral load is high, we need to investigate and probably switch to a new regimen, right? And then also, if a patient has a problem with one drug, we don't stop the ARV drugs one and say, oh, the problem is tenofovir. Let's stop tenofovir and continue lamivudine with efavirenz. No, you either give all the three or you give nothing. Even when there's a stock out, don't say, at least I gave him something. No, you have caused harm. Don't give anything less than 3 drugs. that is the rule, right? We never give NNRTIs together. And if one drug in a combination must be interrupted, all the drugs should probably be stopped. We don't give it like that. So as part of then our reflections, maybe it's best to start with those pollings. I'm hoping you are able to see these results. If you remember our discussion on the first one, which was saying which of the following ART drug class combinations is a recommended first-line combination in South Africa. So it is the one where the 41% one. So one NRTI, so that would be tenofovir plus another NRTI, lamivudine, plus an integrase inhibitor, dolutegravir. So NRTI plus NRTI plus dolutegravir. And then there's one which says, which of the following drug combinations is the preferred first-line ART regimen in South Africa? It is the combination of tenofovir with lamivudine and dolutegravir. So the 72% got it right. Let me see if I can show you the answer for the last one that we did. How do I get there? Yes, so I'll show you. In terms of the one on drug interactions, just for your knowledge, which of the following ARV drugs should never be given in a patient who's got TB and HIV? Taking rifampicin, what is the correct answer? Nevirapine, right? Remember, tenofovir is not affected. Efavirenz is the safest to use with TB drugs. Dolutegravir you can use, but you must double the dose from 50 milligrams daily to 50 milligrams BD. Lopinavir, ritonavir you must use, but you must either double the dose or add additional ritonavir, right? So I'm hoping these questions were very helpful in helping you to learn as much as possible. Just a few seconds. I'm struggling to close this thing. Let me be... Oh. Okay, maybe I must just close it up there. Yeah. So what are the 4 steps for ART initiation? Determine the timing. Check if the patient has been on ARVs before. Which drugs would you prescribe? What test would you do? What is the standard first-line ART regimen in South Africa? Tenofovir, lamivudine with dolutegravir. When will you refer patients based on the following test? If the creatinine clearance is less than 50, if the HB is less than 7, if the ALT is less than 80. However, anytime you have a symptomatic patient, irrespective of the levels, you should probably refer the patient. For a patient taking TB therapy, what drug adjustments are necessary for the following drugs? Tenofovir, no adjustment. Efavirenz, no adjustments. Lopinavir, ritonavir, either double the dose if the patient is taking tablets or prescribe additional ritonavir, especially for those taking a solution or the syrup. Nevirapine, never give with TB drugs. Abacavir, no need to change. Dolutegravir, you increase from 50 milligrams daily to 50 milligrams BD per os. Right. So that's it for today. I really hope that you have managed to get something from this topic. It is a very important slide set. I never teach any HIV course or medicine without discussing specifically the principles, the things that you must do, the things that you must not do, and areas where you really need to pay attention. Thank you very much, for staying until we finish, and I hope this was worth